I wanted to welcome everybody to this, our April 2025 version of the IPA Journal Club, featuring our guests, Deborah Cabaniss and Shirin. Next slide. I'm Jack Drescher. I'm the moderator of the Journal Club. That's my bio there. You can also see it on the IPA website. The next slide. So for those of you who have not been here before, this is, I don't know, maybe our 10th or 11th Journal Club. The past editions of the Journal Club have been recorded. They are currently available both at the IPA website, but also on YouTube. Agustin, who's our technical person, thank you, Agustin, will put the link to past Journal Clubs in the chat for those of you who might want to see some of our past editions. And next slide. So I'm going to introduce our two guests today. Our first guest is Deborah Cabaniss, who is a professor of clinical psychiatry at Columbia University and the director of residency training in the Department of Psychiatry at Columbia. She got her BA from Yale, her medical degree from Columbia, and completed her psychoanalytic training at the Columbia Center for Psychoanalytic Training and Research. She has won numerous teaching awards, all well-deserved, and has over 60 publications related to psychotherapy in education. And in addition to her work in the US, she has lectured and taught in Sweden, Norway, Japan, Korea, Canada, and her books are widely used across the US and abroad. Next slide. Shirin Ali is also from Columbia, where she's a clinical assistant professor at psychiatry and an associate training director at the Columbia University Psychoanalytic Center for Training and Research. She enjoys supervising and teaching and has a private practice in New York City's Greenwich Village. As a matter of disclosure, we're going to be talking about the book, the Psychodynamic Formulation book, which I was a member of the Psychodynamic Formulation project. I wasn't the major writer, but I did help with some of the editing. Just wanted to let people know that. Our next slide. So the goal of this journal club is to be interactive so that you, the readers, can speak directly with authors. And as I mentioned earlier, this session is being recorded and you'll be able to see it on both the IPA website and the YouTube, IPA's YouTube channel. And if you don't want to be recorded, leave your camera off. But if you don't want to be recorded, I may not call on you to ask the author's question. Next slide. If you have any questions or comments, you can use either the Q&A section. We're not using the chat function at this meeting, but you can also use the hand raise function if you want to be called upon. We've been finding that's a useful way, a useful tool. Next slide. When you're called upon, please remember to unmute yourself and turn on your video camera if it's not already turned on. And when you're called upon, please identify yourself. Let us know where you're from. This is an international meeting. We get a lot of people. Although it's an international meeting, not everybody here is a native English speaker, so please speak slowly and clearly. And if you haven't downloaded the paper yet, we're going to put the link to do that as well. The paper, in this case, being a chapter in the book, Psychodynamic Formulation. And I think that's our last slide. Is that correct? Great. Okay. So welcome, everybody. We have a nice turnout today. I'm going to start because I get to start. And so I'd like to start with the history of the Psychodynamic Formulation Project. And this book, this chapter is from the second edition of this book. So Deborah, you were there for the first edition. Can you talk about how the first edition came about and what thinking went into updating the second edition?
Sure. First of all, thanks so much for having me and for all of you for taking time to meet today. It's really exciting to have such a big group to talk about this. And it was also, Shirin was part of, like Jack, was part of the second edition. So I'm really pleased that Shirin could join me here today. I'm also the associate program director. I'm not the program director, just to say that Melissa Arbuckle is the program director, but it's been a totally fun job. And in terms of, conflict of interest stuff, I actually feel really comfortable talking about this book, not the least of which is because we don't actually collect royalties for this book. All of the royalties for this book, all of the authors, which, we in the second edition, we decided to donate all of our royalties to a scholarship fund at the Columbia Center to help people who have difficulty making the, it's expensive to do, et cetera, and also to try to encourage people who have been underrepresented in the field to come into psychoanalysis. So just to let you know that. So, I'm a psychiatrist and a psychoanalyst, and when I was a resident, I really was pretty mystified. Although I was interested in psychoanalysis, I thought that a lot of the materials that were offered to me as a resident, as an early trainee, were not experienced near. They were really designed for psychoanalytic candidates, and I found them hard to read, hard to understand. I also found that, when I was a second year resident, my instructor said to me, go home and write a psychodynamic formulation. That's basically the way I was taught to do psychodynamic formulation. And I wrote like blah, 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 Oedipal, blah, blah, blah. I mean, it was probably some kind of garbage. And because I really didn't understand what a formulation was. And when I became the director of psychotherapy training at Columbia, which was in 2007, I was a graduate at that point of the Analytics Center. I actually became very enamored of some of the materials that more newer evidence-based psychotherapies like CBT and DBT had for their trainees. I really thought, like, these are clear. These give clear goals. Like, you can really understand like what the techniques are. So we started, we meaning the, our initial group of authors who were the instructors at the time, we started to write syllabus materials that we thought would be experienced near for junior trainees. We did not intend to write a book. So we really were creating syllabus materials, not only so that, busy residents who were tired could just read a few pages, before their class, not pages and pages and pages of analytic material that might not even feel relevant to the work they were doing, but also so that the syllabus materials could be read by the supervisors at the same time. So the supervisors could have an understanding of what was being taught in class. We really have this course and lab idea. It's like if you're taking organic chemistry, but you go to the lab and they teach you inorganic chemistry, it's not useful. And too often you go to didactics about psychodynamic psychotherapy, and then somebody goes to supervision and they don't really know what's being taught in class. So they're not really synergistic. So we really wanted to write syllabus material at this point just about technique. And when one of our residents who was from Amsterdam said, oh, can I send my syllabus materials to Amsterdam? My husband said, I think you should look for a publisher so that you could turn this into a book. That's how we started writing books. And what became very clear after doing that, really in an operationalized way, is that we did not have an operationalized version for formulation. And so we set about doing that, again, first with a small group, and we created this operationalized version of formulation, which we really liked. But quite honestly, in the summer of 2020, during the pandemic, and also during the Black Lives Matter protests, I think many of us really felt that we needed to take a good hard look at what we'd written and realized that it needed to be updated, that there was our own biases were showing through. There wasn't enough emphasis on the way that macro system issues, racism, sexism, ableism, et cetera, affected people's development. And we wanted to update the book. We felt unable to do that in our small group. So we created an 11-person, what we called a collective, which included Drac and Shirin and many other people who already had a lot of expertise in some of the areas that we were thinking about. And we did the whole thing over Zoom. So we had once a month, Monday evening meetings. Some sometimes I took a screenshot of that, and sometimes when I give a talk about the process, we had a good time. It was very interesting, and we learned a lot. We read a lot. It was a very felt useful during the pandemic for us. Also personally, I think we got to meet each other, and we created this new edition in which we really updated many things.
Sharon, what was it like for you to be invited to join? Because you're compared to the two of us, you're a relatively junior colleague in this project.
Um, I yes, I'd say I was really excited about the project and also intimidated in the sense of our group was a mix in terms of background, age, seniority, and sort of both excited and intimidated to work with people who have been my teachers over teachers, supervisors, and now colleagues. I had finished psychoanalytic training in 2019, so it was really just right after that that we embarked on this project. And I think one of the things that was very meaningful about it is that we all really felt that we were learning together. There was a lot of the both psychoanalytic literature on the subject of lived experience and systems of oppression that we were all kind of reading together, and also reading outside the field from other disciplines. And it really felt like we were just really learning together and having some, at times like I wouldn't say difficult, but like real some challenging conversations together about how we would, sort of what angle we might present in the book, or how something in particular might be handled. For example, Deborah knows this, and Jack knows this well. We had the whole decision making of should we use names for the cases in the book or not, and we kind of went back and forth. They hadn't been used in the first edition, and we were thinking about the purpose of this book, sort of an expanded look at formulation, and really kind of struggled with things like that in terms of the vignettes as an example. But it felt really, I think, good to be able to wrestle with these things together and kind of think about the implications of each decision we made as a team.
Mhm. I remember working on one chapter where we reviewed the history of psychoanalytic formulations, which included things like the ulcer personality
Yes.
disorder.
Yes, exactly.
That one of the problems, in the field is that of how in some ways, without wanting to acknowledge that psychoanalysis is very much embedded in its own set of cultural biases, to which they sometimes are, blind to those. But there was a real effort in this volume to sort of expand that, not just let us say, in kind of a woke way, but really to sort of expand the idea that, that how can you have a psychoanalytic formulation that does not include the wider world? So I just want to let that we have some latecomers. If you'd like to ask a question, you can raise your hand, the hand raise function, or you can put a note in the Q&A. We're not using the chat function, and we'll happen to call on you. I've prepared a few questions and comments of my own, but we'd love to hear from the audience as well. Hold on. So let me get to what I wrote down. So my second point was, so my second one again, how about the audiences for this book? And because I recall when we were working on the early draft, we saw this as a teaching tool for trainees early in their career. And I think, Deborah, you alluded to that. But do we think this is the only audience for this book? Is it really just a book for trainees?
Well, I hope that it's a book for everyone. Also, in terms of trainees, I think we really made an effort to call people in the book mental health professionals, so that I know that it's used by nurse practitioners, by psychologists, by social workers, kind of across the board, which really makes me happy that people feel that this speaks to them, that they're, it's not doctor patient, that kind of thing. So that feels very important in terms of who the audience is. It's also definitely for educators. So I really had the feeling, and now not just talking about junior educators, but people who do have education in psychoanalytic institutes, both for candidates and for psychotherapy students. I think these books are really designed to be another look, like another lens. And I hope, and I'd love to hear from people in the, who are participants on this call, who are really seasoned clinicians, like what your take is on this. Like, it's one thing for us to design it, but, does it speak to you? Does it give you a moment of reflection about, some aspect of your own practice or your own teaching that, feels useful to you?
We have a hand raise from, forgive me, Mavis Gomez. Could you unmute yourself and tell us where you are? And help me pronounce your name correctly.
Hello, people. Listen to me now.
Yes, we hear you.
Okay, I have a question. I am psychology. I'm from Panama. In London is afternoon, and Panama is morning. I feel good to be here today. What do you think about free association for mental health problem as an example of a psychodynamic project? This is my question.
I'm sorry, could you repeat that? What do I think about free association for?
Okay, see, what do you think about free association for mental health problems as an example of a psychodynamic project?
What do I think about free association for mental health problems?
Yes.
You mean as a clinical tool for working with? It's an interesting question.
Interesting. It's actually something that's covered a little bit more in our first book, the technique book. What do I think about free association? I always say to my students that, and even to patients, if I could do a PET scan or something like that and find out exactly where the problem is in your sense of self or in the patterns of your relationships with others, I'd happily do it. And we could find out right away where the difficulty lies and, get the radiologist to read it, et cetera. But of course we don't have that. So we are kind of, we psychodynamic and psychoanalytic practitioners are like blind moles, right? Under the ground. We have no map. And the only way that we can get to where it hurts, right, is by asking people to say whatever comes to mind. So it's not always there are people who are suffering from symptoms that make free association difficult, or that may make people more symptomatic. I'm thinking of people who have psychosis, maybe people who have severe obsessions, et cetera. So it's not always useful, but when we are doing this kind of work, when we're trying to uncover things, when we think that's appropriate work to help somebody, it's all we got, basically. We've got dreams and we've got other things, which sometimes I say that, there's an old American game called Chutes and Ladders, where you can either go step by step or you can go up a big ladder, which gets you faster. A ladder might get you someplace faster, but free association is a pretty good way to sort of use the idea that thoughts are connected in meaningful ways to get to places where it hurts people.
I agree, Deborah, completely with all that you've said. I think it's really just helpful to contextualize. And I think in working on as a group on this chapter in particular, I think with some of the issues that might come up around lived experience and feelings of power differential in the room, I could also imagine that some people may be more inhibited, as Deborah mentioned, in terms of being able to freely associate, or could use it defensively to maybe stay away from topics that they might feel more vulnerable about. So I think balancing free association as maybe our ideal and kind of keeping in mind, you know, what's happening in the dyad in the room in terms of both people's lived experience and the power dynamics, the advantage and disadvantage too, that one, I think, can be alert to areas that you might have to ask about more specifically if it feels like they've been avoided. And there's some examples in the book. I think there was one, I think it's in an earlier chapter where it was, again, this is sort of US specific in light of the violence against Asian Americans in 2020, where there's a vignette about a dyad where the patient is Asian American and the mental health practitioner is Caucasian, and that they never talked about sort of the racial and cultural difference between the two of them until the violence in society came up, and it was like an opportunity to kind of discuss it more. But even in freely associating in their prior time in therapy, they hadn't had a chance to, or maybe had avoided talking about this topic because it brought up some difficulties in the transference and countertransference.
Yeah, and before I call on Sulav, I was just wanted to add, I was reminded early in my training back in the 80s of, you know, some very traditionally minded psychoanalytic people who would say, you know, like working in our clinic, that it's too bad that we can't use traditional psychoanalytic methods in our clinic because the patients were too ill, you know, to do like a classical psychoanalysis. And I thought, isn't it a shame that you work in a clinic where you don't want to develop your skills to learn other things that patients might benefit from? That, you know, that really, it's really about individualizing treatment. So that's when it's the right tool, then it's great, but sometimes it's the wrong tool. And so that's really, it's not about fitting the patients into the system that we want to practice. It's really about finding what works best for each individual patient. I hope that answers some of your questions. Sulav, could you unmute yourself? Tell us where you are.
Hello, good evening. I am Sulav Ukriti. I am a clinical psychologist from Nepal. And I am not a psychoanalyst, but I do have my residency training. I do take 100-hour psychoanalysis, psychodynamic class, and where our main course and main thing is this psychodynamic formulation of Cabaniss, which we have studied it, and we make our patient formulation also based on this, how the program and person and how the different self defenses work and play different, how we use it from also in our formulation also we have used it as a reference to study it. Yeah, but my part is always I get difficulty. I don't know why I get difficulty, but I more difficulty in link part also. Yeah, the linking part is something I always difficulty while making this formulation. And when I see this GAN round Journal Club from in LinkedIn, and I just register to know how it's going, and I just want to connect it in this group. Thank you so much.
So it's just, you know, I mean, it's a tribute to the International Psychoanalytic Association, but also like what an amazing community of people from all over the world. And you've made my day that, you know, you're using the book in Nepal. It's just terribly exciting to me. You know, it's really not great. What he's referring to is our basic method. People always laugh at us like we can't count past 3. Most of our operationalized techniques really involve 3 steps, which is, you know, so in the technique section, we really think, you know, about, you know, listen, reflecting, and intervening. Those are our 3 steps that we teach. And in formulation, we teach describe, review, link. And with essentially the way we got there is we sat around and wrote a lot of formulations and really thought, like, what are we doing? How are we doing this? And, you know, like around a dining room table. And we really thought it's a formulation is an hypothesis. It's an hypothesis about how someone either comes to be the way they are or the way their mind functions. Like, that's it. It's really what it is. And you can have CBT hypotheses, DBT, or psychodynamic formulations. And our psychodynamic formulations, we believe, take into consideration that what happens genetically, you know, early in life, and also what happens in the unconscious affects the way we develop and the way our minds operate, right? And so, like any hypothesis that you're going to develop, first you need to know what the phenomenon or phenomena are that you're creating the hypothesis about. So that's describing the person, the problem that they come in with, and the person, and all of their different patterns that they have, the way they think about themselves, their relationships, the way they think. We psychoanalysts sometimes forget about that, but we actually spend a lot of time with patients thinking about problem solving and decision making, how they think, how they work and play. I'm very influenced by Myrna Weissman, who's at Columbia, just in terms of like really understanding, how do people relax, or can they, or can't they? So what do they do all day, right? And we've added also, you know, and adapting. We call it adapting. You'll notice in this chapter, which is, I think, illustrative of the other chapters in the book, that we've really tried to get as non-jargony as possible. You can see we're people from all over the world here who use all different kinds of, trying to get to things. So rather than saying super ego function, we've really thought about values. Does this person have a set of values? What is the set of values? Does their behavior adhere to the values? So you have to describe this person, and then you review their life, because we psychoanalysts believe that the life leads to the person, right? What happened before they were born? What happened in utero? What happened to their parents? This is very much, you know, what was the intergenerational transmission of trauma? Like all of these different things. So we describe the person, and then we review, and then we use different, we call them organizing ideas about development. Some people call them models of the mind, to link. This is what the person is asking the question is, how do we link? How do we say this life led to this person? How do we link those things? And we use our models as scaffolding, not because we know or they're right, but we use them as scaffolding. And I like to think of all of these different models, or all of these different organizing ideas about development, as a library. I used to be able to say a Rolodex, but people don't use that anymore, right? But it's a library that, depending on the person with whom you're working, you can kind of walk through this library and say, that model's really speaking to me about helping me to understand how this person came to be the way they are, rather than I'm an X, like, you know, I'm this kind of psychoanalyst. I really love the idea of being able to use these different ideas. So that's the way we use links. So for example, when we're linking, so this chapter that I, you know, offered here, and that Shirin and I, you know, are speaking about today, really provides, you know, a way of thinking about the effects of culture and society as an organizing idea about development, right? It's not enough for us. It wasn't just enough to say, oh yeah, this person was discriminated against, or their family was discriminated against, so they have difficulties. But we really wanted, we don't say, for example, this person had a neglectful mother, so they don't think well about themselves. We think about Kohut, and we think about self-psychology, and what's the actual mechanism by which what happens to a person in a life really gets incorporated into the person's psyche. And we wanted to offer ways of thinking about, like, what's that mechanism? So when we link, we say, I'm seeing this person, let's say this person has difficulty trusting other people. Now I'm going to review the life throughout this person's life, and in the life of that person's family, this person is really in a group that has been dominated or oppressed. How can I understand? I can use that understanding of that experience of the person or of their family to help me to link to what I'm seeing before me today in the room with me, talking to me. Shirin, do you want to add anything to that about the linkage?
Not really. I think you explained it really beautifully and clearly, and I do think that it is I think I was just teaching this chapter in the book to our third year residents at Columbia. Is a class I've co-taught with Deborah over the last few years. And I think it can be I think it takes practice of going through that to use like the files, the different sort of models of the mind, to be able to feel like you get used to linking a bit more. I think it can feel when you're still getting comfortable with it. I think it can feel sort of a bit overwhelming that there's so much to choose from, but it does kind of get easier the more you do it. And as Deborah said, these are hypotheses, and so you're constantly revising your formulations. Sometimes even, this happened to me the other day, someone I've been working with for a long time, we just happened to talk about an aspect of their development that we hadn't, and it really shed some new light on how I see them as really, interesting. But so we're constantly revising and constantly relinking too.
Yeah, it was,
Totally.
one of my mentors, Susan Coates, would say, hold your theories lightly, which is very useful, and hold your formulations lightly. And, they're useful until they're not useful. We have a line of people with their hands up, which is lovely. So David Lopez, hi, David. Why don't you introduce yourself? Tell
David.
us,
David.
tell us where you are.
I'm David Lopez. As Shirin and Deborah and Jack know, I trained and I practiced in the United States most of my time in the New York area. Now I'm in Philadelphia. But I have a lot of contact with people from Latin America. My parents certainly were analysts in Mexico. And I was hearing Mavis, I hope I'm saying it right, Mavis' question, and reminded me of discussions that I've been surprised about coming from the United States and Mexico and some people in Latin America. And I think people in the US thought like this before too, that you did not need really an evaluation process. And you really didn't need to go through a preliminary evaluation and assessment before starting an analysis or a therapy, and that by just letting the patient free associate, that would give you the formulation, which that obviously was not the way in which I was trained, but I thought it'd be interesting to hear your perspectives on what is it, how much more do you get when you go through the process of assessment before you even start treatment and putting together a formulation?
Well, I couldn't even begin to answer that question because I've never done it any other way. I mean, I always do an assessment of person. I'm a mental health professional, and I believe it's important to make a diagnosis and to assess somebody. And I also think that psychotherapy and psychoanalysis, I think of it as like a big pie with lots of slices, right? Psychodynamic psychotherapy is one slice of the pie. And there are lots of other kinds of treatments that might be better for people than psychodynamic psychotherapy. Sometimes people come to me and they say, but I want to be treated by you. And I say, but, I think your major problem has to do with substances. And I think a different kind of treatment would be more useful. And I'm going to refer you to somebody who has expertise in that area, let's say. So I always do a careful diagnostic, but also this whole idea of looking at all the different patterns and sort of getting a sense of that. Not there's Shirin is saying that evolves over time, but I always do that. I think that I know that people disagree, but that's always been very important to me and is part of the way I trained and part of what I think is really important.
Thank you. Thomas Flanagan, you have your hand up.
Yes.
Could you tell us where you are? And
yes, I'm actually I'm a graduate student in clinical psychology at the Chicago School LA campus. I'm very new to psychodynamic and psychoanalytic thinking, but I have been using this book actually in my supervision out here in LA, and I've really enjoyed it a lot, and I have found it incredibly helpful, especially the method that you were talking about with the describe review link. I've been using that with my supervisor, and it's been very, very, very helpful. My question was in the book, because I have the book and I've read it actually a couple of times. And my question is in one of the later chapters, I believe it's 27 or 28, where you guys talk about the collaborating with the patient and to come up with the conceptualization, the formulation, and talking about how it can be therapeutic and helpful to give sort of a life meaning or a trajectory of their life, or having the patient collaborate and helping them understand maybe they're generating the life narrative, I think you guys call it. And I was just curious if you could talk about maybe what guides your thinking about when you do that, when you don't do it. I know the book mentions, you know, kind of using your own countertransference, and I was just curious if you could elaborate more on that process of how you do that. Anything would be helpful.
Yeah, totally. You know, it's a great question, and it brings me back to a moment when I was talking about the first edition of the book at the Boston Psychoanalytic, and Anna Ornstein, who is a great psychoanalyst and scholar of Cahushian theory, stood up and said, "You're telling me about your formulation, but we make the formulation together with the patient. We make." I felt like that's such a good reminder that we're always, so really when I mean, I'm going to answer your question in two different ways, because the fact is we're always sharing our formulation with the patient, because anything that you say to the patient other than or you know, it's time to go, like is sharing formulation. If you say, you know, I wonder if the issue that's happening now might be related to X, that's sharing the formulation. And then what happens is this fabulous, you know, it sounds like a cliche, but dance really, right? Where the patient says, yes, that makes me think of, or a little bit different, and you shape it together. You're always doing it together. And in fact, sometimes I'll say something and the patient says, no, not at all. It's this. And I say, oh, yes. It's that, you know, so the patient is, which this is this co-constructed thing all the time. I don't want anybody to think that we like write up a formulation and say, oh, you know, read this before your next session or something. Hardly. But sometimes, you know, when, there are moments where, for example, you really realize something is getting consolidated. Like we've seen this with this person, and we've seen it with somebody at work, and we've seen this kind of pattern that you will say to somebody, I mean, we do this all the time. Let's just take a moment and see where we've been, because I think we've really learned together that this pattern has been, you know, you kind of give a little chunk and the person responds to it. So you're doing this all the time. Shirin, do you have any other thoughts about, you know, this sharing of formulation?
Yeah, I think I agree with what you've said, that and it's hard because I think it's probably you know, takes some sense that's hard to describe or put into words of the feeling in the room. Maybe it's a particular kind of crisis point for the patient where you're seeing this pattern unfold yet again or yet in another domain of their life, and they're really receptive to hearing that kind of consolidation or maybe a bigger chunk than they've heard. But I agree with Deborah that we're kind of constantly doing this, even if sometimes you're just repeating back to somebody in a somewhat metabolized or consolidated way what you've understood from, you know, what the troubles they've been experiencing and how they've related them to you on that day. It is a bit of giving that back. So I would suspect you're already doing it, and maybe if you're, you know, attuned to the fact that you're already doing it, it's going to become a little bit more evident to you, or it's like, oh, you know, we had one of those moments. This, you know, this came up in our session this week.
Beautiful. Thank you.
I'll ask some stuff later, but because we have a couple of hands up. Susan, hi, why don't you introduce yourself and tell us where you are?
Okay, I'm in New York, Susan Warshaw. I'm on the faculty of NYU postdoctoral program and also the William Allenson White Institute Child Adolescent Program, and I could go on. This is wonderful. I've been an educator, psychotherapy, psychoanalytic educator for most of my professional life. And this reminds me of trying to teach a course in adolescent psychotherapy many years ago, in which I was trying to teach a psychodynamic perspective. And I came across a book on from the core competencies theory series from the American Psychiatric. It was like a godsend because it was beginning to do what you are trying to operationally define what we do. But fast forward, it just occurred to me as I'm listening to this, and I really look forward to reading your book because there are many books that try to deal with diagnoses. I'm thinking of Nancy McWilliams' work and so forth. But I love the need to operationally define, but that too strikes me as a culturally determined need right now, at a time when people are suspicious of what psychoanalysis is or don't really understand. I'm thinking of patients, and I'm also thinking of professional associations, and how we're in an era where everybody wants to know exactly what do we do. I'm on the APA, American Psychological Association Council of Representatives, and we just went through an approval process for a new PTSD guideline. And among the issues was who does meet the criteria of empirically supported to fit into this guideline. Psychodynamic therapy was considered insufficiently having insufficient evidence, and but narrative therapy was recommended in the second tier. And I looked at the definitions and I kind of laughed, because if you look at how they operationally define, it's not funny, but it's really important politically, is what I'm thinking, both for our patients and ourselves, because we live in a culture where everybody wants to know exactly what do you do, when you do it, what are you really thinking? And so this, I am excited by what you're doing. I'm thanking you for what you're doing, but I also think it leads to the possibilities of doing better supportive research that others will see as validating the work, the very significant work that we all are trying to do. So I just want to say that, because it just struck me as I was looking at this thing, and I was doing a lot of pushback on how these decisions were made of what's considered valid. And then this goes out to the public, you know, who does what and what's considered a good treatment. And narrative therapy, if you look at the definitions, it's so much. So I'm wondering what you think. Have you thought about the current culture and how we're being pushed to do this? Because there's no longer faith that what we're saying we do is bought into, essentially, by many people in the dominant society. So that's just what I want to say. It's a lot.
Yeah, well, people shouldn't have faith. Faith isn't that what we're talking about? You know, somebody wouldn't say to you, like, take this heart medicine. There's no, just have faith that it works. We haven't researched it. I would say, forget it. I'm going to the next person, you know. So I think it's critically important. And I think there are a lot of people who are really thinking about operationalizing things. Barbara Milrod, Fred Bush, Peter Fonagy, who are really looking at, and, you know, if you look at mentalization-based treatments, this is very, you know, certainly next month, this is a little teaser for next month, will be TFP. And TFP is really an operationalized approach to a psychodynamic psychotherapy. And there's, like, you know, there's good research to back it up. So I think that operationalizing things in this way is, I mean, I do it. So I think it's useful. I think it's useful for me personally. I think it's really useful for education, but it's absolutely critical for doing, you know, research based on different kinds of treatment. Otherwise you can't measure adherence among the research therapists. I mean, you know, because you sort of say, like, go out there and just do it. You have to really say what it is and be able to train people in a manualized way. Our first book, we called a manual, you know, and I have no shame in calling the book a manual. Like, I think manuals are really important, but manuals, people sometimes think about manuals like as they're cookbooks. They're not cookbooks. They're, you know, they explain, they have techniques, they tell you what the goals are, they tell you how you're going to measure whether things work. They're really critical for doing exactly, Susan, exactly what you're talking about. We should, and we all, I think the one thing I would say is, like, let's not feel pushed to do this. Let's feel inspired to do this. Like, this is what we should be doing. This is what we need to be doing. This is the way And if we find out that some of the things that we're doing don't work so well, let's change them.
I agree.
Susan, I would also add that I think psychoanalysts as a community, are not comfortable getting out there and talking about what they do and why it matters and why it's important. And that, that one of the traditions we've inherited, I think, from previous generations is sit in our office and wait for people to come to us, and I think that really is, the culture has changed in many ways. People don't come to us just because we think we know everything. So it's really important that psychoanalysts are out there in the public domain sharing their ideas in a way that people in other fields are doing that. If otherwise, who's going to pay attention to us?
As you know, Jack, I'm just now editor emeritus of the Journal of Infant, Child, Adolescent Psychotherapy, where we have published a great deal on all of these issues, including MBT, and co-sponsored a Congress in Barcelona with Anna Freud Center and so forth. So this is where I sit. What I was thinking of, though, I didn't mean to suggest people should just take us at our word. I don't think anybody does, but there's an ever-growing need for us to really put out there what we do so that people understand it.
Yeah.
I recently had a patient who decided he should go to an IFS therapist in addition to me, doesn't want to leave me, because he will work on his parts. And I thought, oh my God, what have we been doing that you don't even understand what the kind of process that we are going through. So I have to backtrack again and re-speak it. So I think this kind of a book is very critical. So thank you. That's it.
We have another question. We have a couple of people waiting. I forgive my pronunciation. Kanak, could you introduce yourself and tell us where you are?
Sure. My name is Kanak, and I'm based in Mumbai, India. So it's really great to be here and read the chapter and be here, because I was a graduate student not that long ago. It's been around half a decade, and the first edition of the book is actually the one thing that I found that made me feel like I finally understand what a formulation in psychodynamic therapy looks like. And so this chapter was really interesting to see, because I think I went back and I checked with the first edition that this wasn't there in that one, and this is something new. Yeah. And my question comes from that. And so I practice, I'm a therapist, and I also teach a graduate program, and it's coming both from things that I see in the classroom as well as in the virtual clinic. But I was wondering what your thoughts are about balancing societal cultural factors along with individual psychodynamics, both in formulation and in therapy, because while it's of course important for patients to understand the great influence that systemic factors do hold over our lives, I also find that sometimes it almost feels a bit disempowering to take a whole stock of all of the very many things you don't have any control over. And so in the spirit of really a collaborative formulation and sharing our formulations, how do we go about balancing that there are all of these systemic factors that we need to acknowledge, and yet we find some agency to work with things at an individual level, because that perhaps is all we can do in therapy. Yeah.
Well, I'll bet that Shirin is going to have a lot to say about this as well. But first of all, I'll say that what you said to me at the beginning of your question is why we wrote these books. It makes me just, happy and proud, really, that to have that feeling of like, I get it. Like, it makes sense. It's supposed to make sense. Like, it's not supposed to be opaque, right? So it's supposed to make sense. So I'm really so pleased that it made sense to you. One of the reasons why what we do is so interesting, and that, people worry that we're going to be replaced by like AI or something like that, is that it's really an art and it's complex, right? So we have to balance all of these things all the time. We have to balance, and it's part of why we were so attracted to this model of Bronfenbrenner, which is the microsystem, mesosystem, macrosystem, which Bronfenbrenner was an ecologist. He worked at Cornell, and he was really thinking about ecological systems. The notion that you can't just study, for example, a frog. You have to think of like the frog in the pond, in the meadow, right? And if you don't think about all of them, you're not really understanding the life and the physiology and the behavior of the frog. You can't do it. The same with us. the same with us. And I think psychoanalysts have been super, super good for a long time on the microsystem, you know, like how did your mom and dad, you know, or your caregivers really affect you? And we've left out a little bit. I mean, we've left a lot of things out over time. We've left out temperament, we've left out, you know, different kinds of things, but we have not always thought of what's happening in the community and how that affects the growing person and the family, and what's happening in the society at large, meaning like the laws, the mores, the biases, et cetera, that are in the society, the systems of oppression. And I think what's exciting about the work that we do is we have to constantly balance them. Like, how do we do it? We have to have them all available to us and also to the person with whom we're working, so that they know that these are things that are important to talk about. And then we bounce. And sometimes one is going to feel like it comes to the forefront. I'm not even going to say more important, because that's judgmental. Like, one's going to come to the forefront and be more helpful at that time. And then another one will, and we'll say, and it's this and that together. It's a both. Which I think this is just expanding. I think we call this an expanded approach. For me, it's just really expanded and in such a productive way for people to begin to think about how things affect us. I don't know, Shirin, what's your experience been?
Yeah, I agree with you that it feels, I think you used the word in your response to a prior question about a dance. And I really feel like it's a dance that we're constantly doing to kind of toggle between, you know, thinking about the macro system versus the, in addition to the microsystem, sort of having that in mind. And Kanak, I really liked your word agency as a concept, because I do think that's also, you know, really helpful to kind of constantly keep in mind, like, how can we help everyone we work with develop a sense of agency, maintain it, increase it, and, you know, what do they have control over in their lives? Sometimes there might be very little control over kind of big societal things that are going on, but what can they do in their relationships? What can they do to care for themselves? What can they do to sort of help develop and augment that sense of agency? I think is really important. Like, someone might feel, you know, that it's very important to advocate about something very big going on in society, and may also be doing some of that work in their own relationship with their partner at home, in terms of balancing domestic labor at home or something like that. So those two can really, as an example, a brief example, can really be going on simultaneously, and you as the practitioner, you know, is trying to keep all of that in mind and work with also kind of what's at the surface, I guess, any given day.
Also, you know, just what you're saying, Sharon, brings something else to mind. Of course, we can't change the macro system. I don't know about you. I could never change my mother either. So, you know, it's not like we could change aspects of our microsystem very much either. And it's not a question of changing what's in the macro system, but having an acknowledgement and an understanding of the way that we've developed and the way that we think about ourselves, our relationships with others, the way we adapt to stress, the way it's, and this is the person who asked about how do you share this, the way in which our narrative, our personal understanding is of the way we developed and all of the different factors that went into that.
And the relationship, of course, with your practitioner is so important here too, in terms of developing that sense of agency and understanding, and having that acknowledgement that Deborah's talking about too. It's really powerful.
Sylvia, I'm going to call you in a second, but I just wanted to add the comment. I was thinking about the psychoanalytic concept of the reality principle, as if psychoanalysts were the final arbiters of what constituted reality in conversations with their patients. And we know where that took psychoanalysis. So I'll go on. Sylvia, why don't you unmute yourself, introduce yourself, and tell us where you are.
You hear me?
Yes, we do.
Okay. I am Sylvia Halperin. I live in the United States in Massachusetts. I was psychoanalytically trained at the Massachusetts Institute of Psychoanalysis. I have a private practice, and I work at the Department of Psychiatry of one of the hospitals that is affiliated to Harvard Medical School, the Cambridge Health Alliance, the Cambridge Hospital, and I am part of a multidisciplinary program in which we do clinical work and we train students. And being a psychologist, I participate fundamentally in the training of psychologists, students, but also in the training of psychiatry, social work. I really thank you, Deborah, and you, Jack, for the presentation of this perspective. This is our perspective, but unfortunately, in the United States and now in the Department of predominantly in the Department of Psychiatry of the hospital, it's a group of hospitals, but the hospital in which I work, evidence-based programs are considered to be the only scientific programs, models of treatment, and psychodynamic treatment is not considered to be evidence-based by most of the clinicians. This is a new wave. Our hospital has had a long tradition. You probably know very well-known people who have been part of the Psychoanalytic Institute, who were our big masters in the history of our Department of Psychiatry. But they have left, some of them due to certain important disagreements, some of them because they retired. So in my formulations, I am going to use, this is a parenthesis, I am going to use a different terminology because unfortunately, I didn't know this so important book, Deborah. But our approach to psychodynamic formulation or to formulation is to integrate the sociocultural, relational, and intrapsychic perspectives, both unconscious and conscious aspects, implicit or explicit. I have agreed with everything Deborah said. I couldn't be happier because really, this is what I do when I work. And I also think that it's very important to diagnose, to do a diagnostic formulation, to do, to include, obviously, I would say to do a psychodynamic formulation because I always include, obviously, unconscious psychological processes, explicit and implicit processes, and I want to know how the human being that I am treated has come to be the person he, she, they are, is today. So I want, basically what I want is to thank you, and I am going to read the book in the next future time, in the next time. and I feel very enthusiastic. What I want to point out is that, unfortunately, in the place in which I am working as part of an institution, of a hospital, a clinic, not in the multidisciplinary program in which I work, but at the hospital, psychodynamic, psychoanalytic thinking is considered not to be scientific, because it's considered that it's not meeting the criteria to be an evidence-based program. Something similar to what Susan said.
Yeah, I would just like respond to that and would say, well, that's a prejudice that's not based on facts, that there is ample evidence of the, empirical basis for many psychoanalytically oriented treatments. But in a sense, what you're really describing is not about science, it's really about politics within science. And so that is a really hard one to solve, unless unless you put more people, within those departments who are able to sort of like argue and present that data, but there is data out there.
No, I know.
Yeah,
I know.
I know.
I really know
Yeah,
that it is
Right,
evidence-based,
yeah,
but I am thinking about
right. I'm just letting the rest of the audience know what you know. We have a couple more people with their hands up. I know, Deborah, Shirin, you have anything else to say?
No,
to
I
this?
know we don't have
Yeah.
very much time, so
Fine.
let's just go ahead with our
Okay.
questions.
Sounds good.
Go ahead, Howard. Could you unmute yourself and introduce yourself and tell us where you are?
Okay. Howard Gorman, I'm calling, I'm in Toronto, Canada. And I'd like to ask a clinical question to Deborah and Shirin. In terms of your patients, you're encouraging them to talk as freely as possible. We call that free association. Of course, it's not free, and that's the whole point. But you want them to speak as spontaneously and as unguardedly as possible. And yet it sounds as well from the way you formulate your formulation, you have a lot of categories that you address and you address with the patient. That must create, in my mind, a tension between the spontaneity of associating and the structure with which you are both viewing them and giving them to view themselves in. How do you handle that tension so that the spontaneity of associating doesn't rigidify into a category, into a kind of simplistic categorization of what responses and what associations mean what particular dimension of the set of categories that you use?
Thank you for this question, because I hope that it will help me to clarify the way we do this. We don't use this as like a semi-structured interview in any way. All of us have always had categories that we have in mind, that we want to hear about childhood. We want to hear about, Erickson came up with them. People have had different kinds of categories that we're interested in. This helps me organize what I'm thinking about and the kinds of things I'm asking, but I'm in no way, saying to people like, let's talk about yourself, let's talk about your relationships, etc. It's reminding me and reminding my students of all the different kinds of things that they want to learn. And also, once I get material from people, it's helping me to kind of put it together. So I hope that's clarifying, because it doesn't, I don't do this as a semi-structured interview. But I will say though that, I've had students who if I'm supervising them and I say, well, does this person have any friends? And they say, oh yeah, loads of friends. And they say, well, tell me about those friends. And it's clear they don't have like a depth of understanding of who, like, are the friendships mutual? Are the friendships give and take? Are the friendships secure? Right? What this is really helping students have a real sense of is it's offering opportunities for questions, right? And it's sort of helping with, how do you ask certain kinds of things? It doesn't happen over one session. I mean, I might not fully learn some of these things for a year. I don't know, just the same way as we did in the past. But ultimately, when we're creating formulations, some pieces are missing at the beginning, and then they're going to be filled in. But is that helpful, Howard?
Yeah, I was just wondering how I mean, it's something that you would have to face, and I was just wondering how you deal with it, that's all.
Yeah, I agree with Deborah that we've always had kind of categories and domains in our mind in terms of things we privilege as psychoanalysts, and I believe that this, at least speaking to this chapter in particular, I think these are some aspects of people's lives that haven't been really given much privilege to in terms of formulating people. So I think even at a minimum, if an experienced analyst or clinician were to read this chapter, it might just give them more to have in their mind of like, oh, there's been a avoidance, or we haven't talked about this topic, or maybe I'm not going to ask about this thing, but maybe this is something I'll listen for, use this lens to listen to the material, in this way, from this kind of vantage point.
Okay, thank you.
And we have a few minutes left, and Susan, I'm going to call on you, but I just think, in the interpersonal psychoanalytic tradition, you have something called the detailed inquiry, which is sort of the opposite of doing free, listening in a free associating way, where, the therapist is encouraged actually to, probe, into trying to get information that isn't available by methods of free association. So in a sense, I think what everybody's saying is, if you're thinking long-term, there are moments when you are listening and allowing people to free associate, but there may be moments when you may decide to put on another hat and use a different tool in the therapeutic process. Susan, you had a comment to make before?
Just a quick, I put something in the Q&A. I don't know who sees this. I've been dealing with the issue of what's considered effective efficacy and evidence-based and so forth within the APA for many, many, many years with the American Psychological Association. And what I've come to realize and learn, and we just had this battle on PTSD guidelines literally in February, that the guidelines have to follow the guidelines of the Institute of Medicine, now the National Academies of Medicine and Science and Engineering. And they go along with the guidelines of what's effective of all kinds of associations all over the world. So it is not sufficient to say that the particular institution has to determine, but depends on where their funding comes from and what's considered effective treatment and so forth. So I think it is political, Jack. I just wanted to reinforce, and it's huge political, which is why this sort of book is so important. So that's all I wanted to say.
And I put in the chat, Linda Michaels was on the call, who's in charge of the Psychotherapy Action Network, has provided a link of where there is information about where there are random controlled studies. Paul, we got a minute or two. If you got something brief to say, unmute yourself and introduce us. Tell yourself where are you?
It's a very brief comment from Anna Freud, actually. When I was in London years ago, she said that about a particular patient, she said, I've been working with this patient for 4 years, and today I hear something and I have to completely redo the formulation. So formulation is always a work in progress, even for someone like her.
Well said by Anna Freud through you.
Yep.
Right. So I think we've covered a lot of territory today. I think any last comments, Shirin, Deborah, any final comment based on what you've heard today?
I just appreciate having this conversation with everyone here today. It's wonderful to have this conversation with people close to training, close to teaching, and senior clinicians. It's really wonderful.
Yeah, thank you for the opportunity, and thank you for those who have shared your thoughts about the book. It's very meaningful to us. sometimes you write something and it goes out into the ether and you don't quite know how it lands. So we're really so happy that feels clarifying for something that's vitally important. Without formulation, you really can't do a treatment. And unfortunately, a lot of people are very daunted by formulation. We're hoping that this new edition is adding additional facets. But we're really glad that it's helping people to understand formulation in general.
Great. And I was thinking, we have our last slide? Because we're gonna advertise. So our next journal club will be Friday, June 13th, the same time as this one. Our guest authors will be Diana Diamond and Frank Yeomans, who are two of the editors and authors of a book on treating pathological narcissism with transference-focused psychotherapy. And so if you've been registered in this column, you should be getting notifications of future events. If not, you can always reach out to me. I'm happy to share that information. And again, I'd like to thank Shirin and Deborah for coming today, for giving us their perspectives on this, and a round of applause. Thank you.
Thank you for inviting us.
Thank you so much.